common myth about migraine is that it's something which only happens on the half side of the head. The two most common triggers are the sleep and the dietary habits. We use a very simple tool which we call as a headache diary. That is making a note of every headache you get. So as you grow older, the risk of getting stroke increases. Brain cells, they are dependent on constant supply of oxygen and glucose. So every minute you are losing 1 million neurons every minute of yours. So time is brain. Every forgetfulness is not dementia.
Yeah.
And dementia is not normal aging. Seizures is a symptom which usually happens because of the abnormal extra electric voltage which happens or spark happening inside your brain. The most common reason for any breakthrough seizures is poor drug compliance. If you see someone who's seizing in front of you, the best thing you can do is not to restrain. You need to clear the surroundings. If they are diagnosed on time, they are given the optimal treatment, they can lead a perfectly normal life.
Welcome everyone. So viewers and listeners, we are here with a new episode of Tata Energy podcast, and today's topic is neurology. We have an eminent neurologist, Dr. Manish Mahajan. He is Associate Chief of Neurology in Artemis Group of Hospitals. So let's navigate the topic of neurology with him. Welcome Dr. Manish to Tata Energy podcast. We'll be using your vast experience to enhance my knowledge as well as viewers' knowledge on neurology.
Thank you, Dr. Nag, and thank you, Tata 1MG, for inviting me to this podcast.
So, Dr. Manish, as we understand that neurology is a broad field covering brain, spinal cord, peripheral nerves, we'll try to cover topics related to that. That is, whether it's stroke or headache, epilepsy, dementia. So, let's start with simple thing, that is headache. It is such a common complaint in present stressful world that person has a headache. So, when it is alarming, when to go to a neurologist, if you can just help out over there.
I think it's a very good starting point. If we talk about headaches, when we understand headaches as two major types of headaches. One is a primary headache and the other one is a secondary headache.
Okay.
Now, when we say it as a primary headache, that means we are talking when headache is the disease as well as the symptom. And when we say secondary headaches, that means the headache is secondary to some other underlying cause. Now, it can be a brain tumor, it can be a brain infection, it can be any other secondary infection of the brain or bleed inside the brain. But as very rightly questioned by you, that what could be the warning signs and when to look for that these headaches, whatever someone is experiencing, could be secondary.
Yeah.
So this is something which we call as the red flags in headache. Now, any headache which happens in extremes of age, that means it is happening in very young people or starting after the age of 50 years. That means it's starting at the age of 50 or beyond. Or it is happening in the setting of a fever. Or it is happening accompanied by any loss of consciousness or any focal neurological deficit. That means a weakness of any part of the limb or a speech deficit. So these are the headaches where you should be definitely consulting a neurologist or a doctor. Another thing is when someone has headaches in the past but develops a different character of that headache. Right? So someone develops a very severe headache which happens very all of a sudden. That means just like a thunderclap. That means what we definitely call as a thunderclap headache. That means the peak, it reaches its peak within 60 seconds. So that is something which you should be aware. Many times these types of headaches happen after any strenuous activity, like when you are swimming.
Yeah.
Or it happens sometimes even ascent or descent of the flights even. So you have to be careful that these sudden onset of headaches, which are very severe in intensity, may culminate in vomiting also. So they can be secondary headaches. So that is when you should be consulting a doctor or a neurologist.
Let's start with what you said, the primary headaches. So migraine is the most common primary headache, and I think must be the most common disease which you must be encountering in your OPDs. So what is the common symptoms, common problems with which patient comes to you, and if you can put some light over there?
As I mentioned that migraine is the most common neurological disorder and the headache type which we see in our outpatient department. A common myth about migraine is that it's something which only happens on the half side of the head, or it is something which will never start in young adulthood. So one thing which I want to mention is, yes, uh, that it is a disease of the young people, but it can still start in childhood or adolescent age group. The other important thing is that not all headaches will start only in one half of the head. They will start and they will spread to they can involve the whole head also. And the other common thing is about migraine is that the people, while they are having the headaches, they will have an increased sensitivity to light and sound. They can experience nausea and vomiting also. Yeah. But this is the headache phase of the disease. If we talk about migraine in total, it's an episodic headache to start with. Okay. So the episodes of headache, they are preceded up to 24 hours by very common symptoms like yawning, increased irritability, decreased concentration, or increased craving for even sweet foods. So at times people say that they crave for chocolates or anything sweet coming on their way.
Over the period of patient can relate to it and can act early. Does it help?
Yeah, if they are educated well or about the disease, yes, they can know that, okay, if something like these, their common prodrome symptoms are happening, they are bound to have their migraine headaches coming up in the next 24 hours or so. So during these 24 hours, one can anticipate that they can get the headaches. So migraine, if we need to understand, there are multiple types of migraine further. But for general public, someone has to understand that this is the common migraine which we call, that is the migraine without aura. Yeah. So we have a prodrome phase, then we have the headache phase, and even now the headache phase is something which can last anywhere between 4 hours to 72 hours. That means the same episode can continue into the next day or even the third day. So people at times tell us that my 3 days get spoiled. So it's a huge burden which can be there on their activities.
So common. And there are people who say, if I take medicine early at the start of headache, migraine is aborted. If I don't take it early, it is not aborted.
Perfect.
Does it work really?
Yes, it really works. Because if you treat your acute episodes well, you not only control your headaches better, because there is something when the headache is setting in. Yeah. So you use the right word, that is aborting an attack. So it's the preventive medications work best when you take them regular basis, but acute medications, they work the best if taken at the onset of the headache or within first hour of the headache, because that is when up to 4 hours the attack is establishing. So at the max, they should be taken best between first 2 hours of the attack, and then not only you curtail your headache, you also control your postdrome. So that is up to 24 to 48 hours after an acute episode. People feel like they have been like beaten up by someone. Yeah. They feel fatigued.
Lack of energy and fatigue.
Yes, they feel a lot of fatigue. So again, they are not able to concentrate on your work. So this whole thing comes in cycles. So the interval between the two attacks is something which is different for everyone. So when this interval is more and the headaches are quite infrequent, we call it as episodic migraine. When the headache days are more than 15 days a month, we call it as chronic migraine. And these are the people who have severe attacks or who have prolonged attacks. These are the people who need regular medication. There is another set of patients and they are 1/3 of the patients, they experience some abnormal neurological symptoms, most commonly visual. So they can have colorful spectrum in front of their eyes, or maybe some white spots coming in front of their visual field. And traveling across their visual field. So these types of symptoms, which we call as auras, is something which classify the migraine as migraine with aura. So these people should be on certain set of medications, which we call as prophylactic medications or preventive medication.
And does migraine have any relation with stress?
Stress is one of the triggers. So I was about to come, that most important thing to understand. So we talked about acute medication, when to take it, and how to use it. We talked about who need preventive medication. That is the frequent migraineurs, bad migraineurs, those who have prolonged or severe attacks. But most of the people, if they really want to control, because I told you that migraine is a tendency to have headaches.
Okay.
So there is a genetic component to it, which no neurologist, no doctor can change. But obviously, we can have a good control over headaches, their frequency, their duration, or their severity. So what controls the best is your lifestyle modification and your identification of triggers. So how to do it? So lifestyle modification, when we say, the two most common triggers are the sleep and the sleep hygiene and the dietary habits. So if you have to sleep on time, and the duration and the timings have to be very disciplined. Migraine brains, I always tell my patients that they are brilliant brains, right? Because it's a brain disorder. So you ought to have brains to have migraine. So migraine is basically, they are rigid brains. So they don't give you the flexibility to have food, any delay or any skipping of meals. So that has to be preventive. Other triggers, which can be unique to everyone, have to be identified. How to do it? We use a very simple tool, which we call as a headache diary.
Okay.
Right? So that is making a note of every headache you get. So when we leave it to memory lane, then people only make note of only severe attacks. They will never come to know about the mild
And
attacks.
at times people try to relate to what they've heard of.
Yes.
It got precipitated with coffee, it got precipitated with
Yes.
that, and they will always relate to that only.
So when you have triggers, you will have some relieving factors as well. A very good point you raised, that coffee, because caffeine is related to migraine in a bidirectional way, I would say. It has got two facets. So if someone is in habit of taking coffee or tea at a particular time, then the caffeine withdrawal at that time can also trigger migraine for those people, right?
Okay.
And at the same time, any excess of caffeine can also trigger it. So that is how the caffeine is related. There are other triggers also. I mentioned that when you make note of your headaches, then please look for some common factors, which are can be something in diet. At times, some type of lentils, they particularly give you headaches.
Moving on to the next topic, I like to pick what is called as brain attack, brain stroke, or paralytic attack. This, I feel, is something which is very much preventable, and if timely treatment given, we can prevent the morbidity also. So, as a neurologist, can you please tell how to move about it, and what are the symptoms, first symptoms of brain stroke?
Brain attack, as people should understand, is a disorder which happens due to abrupt diminution of blood supply to a particular part of the brain. Right? Now, I talked about abrupt. Now, the word stroke, which is the actual medical term for brain attack, has come because it strikes you like a lightning. So that is the word which we use, stroke. So there are very common mnemonics which we have given. Indian Academy and the Neurology fraternity have provided you as be fast. So if we say be fast, so we are using balance. B is for balance. That means anything which starts abruptly, like this. Okay. So B, balance. E is eyes, right? F is face. A is arm or leg. S is speech. And T is time. Now, if like this, you lose your balance or you lose your limb coordination, you have a diminution of vision from one eye, or you have double vision, you have blurring of vision, if you have asymmetry of the face, especially on the lower half of the face, if you have any one-sided arm or leg weakness, or one-sided arm and leg weakness or numbness, you have slurring of speech, or you have a difficulty in understanding speech, or you are not able to express yourself, then you have to reach the medical emergency room in time. Because stroke, which we understand, I told you that it's because of the abrupt supply deficit to the blood supply to the brain, because it is
blood
dependent.
supply goes, oxygen goes.
Brain cells, they are dependent on constant supply of oxygen and glucose. So every minute you are losing 1 million neurons every minute of yours. So time is brain. So that last T is the most important. So in case this is because of a clot blocking your artery, if you reach your medical emergency room on time and they have a CT facility at least, you can be offered, if the center is equipped, to give you a clot buster therapy if you qualify for that. And you can basically, the whole set of symptoms, as you rightly mentioned, this is a preventable. And if timely management is done, then you can prevent the morbidity.
Yeah.
Because once the deficit has set in and it is permanent, or whatever recovery is a natural
Will be all
process,
a rehab
natural
part,
process,
practically.
rehabilitation. So once the deficit has happened, you can reverse it by using a clot buster therapy, or certain centers are even equipped for even removal of that clot by using something called as
Interventional
the
radiology.
interventional techniques also.
Yeah.
For importance of time, now we call it as SAME.
Okay.
That is something which we now use because it goes more in line with Indian thing. They will understand the value of time in management of stroke.
Very important point that we have to act very fast when it comes to stroke, and everyone should be aware of the symptoms and where to act, not to neglect even if they start.
Yeah.
And as we understand, brain cells don't regenerate easily, so what is lost forever.
Yeah, because Dr. Nag, an important message is that every chest pain is not heart attack.
Yeah.
But unless proved otherwise.
Okay.
So similarly, suspect stroke, because we do get people who just sit back, it happened transiently, they just say it got better, we didn't reach the ER, or we were just waiting to get better by the next morning. That's the golden time which is lost.
At times, transient ischemic attacks are part of a prodrome. So if they reach in time,
Yes.
probably that is great.
Yeah. But TIAs are to be taken as seriously as stroke, because there is the time where you can prevent the morbidity. There are two types of risk factors for stroke. One is the modifiable and the other one is non-modifiable. I will mention non-modifiable because people say that I lead a very healthy lifestyle, I do yoga, I don't smoke or I don't drink, or I don't indulge in such activities which can put me on risk of stroke.
Yeah.
But why did I get it? So you need to understand there are certain non-modifiable risk factors like age, very important. So as you grow older, the risk of getting stroke increases. Secondly, any family history, any first degree relative like your parent, your sibling, someone who got a stroke, your risk of stroke increases.
Yeah.
Then there is your previous history of stroke. If you got a stroke in the past, then it increases the risk of another stroke. So this is something which you can't modify.
Yeah.
But obviously, when we talk about it as a public health issue, we are talking about preventable risk or modifiable risk factors. In it, the most important is hypertension.
Yeah.
Right?
Uncontrolled.
So uncontrolled hypertension. So you need to treat your hypertension, blood pressure, and you need to optimize it either by indulging in regular physical activity, decreasing your salt intake, or if advised by your medical practitioner, regular medication, antihypertensives. Same goes for your diabetes control. Another thing which is important is your dyslipidemia, that means cholesterol issues.
Yeah.
So we know that LDL is a bad cholesterol, and with exercise your good cholesterol increases, that is the HDL, and even triglycerides, which is you're dependent on your sugar intake
Yeah.
more than your fatty intake. So that is something which is to be curtailed. Then your smoking, very important, and heavy drinking, alcohol consumption, that is something which is to be curtailed. Even substance abuses like cocaine use, this puts you on. So when we talk about these risk factors, these are the something which we call as traditional risk factors.
So
Obesity.
what I can make out is that there is a predisposition to first stroke, but what all you can modify.
Yeah.
Say you are going for a preventive health checks, getting your lipid profile timely diagnosed. If you have diagnosed dyslipidemia early, probably there will be interventions of the drug or the exercise which will help you correct it, and you may either prevent the stroke or you may delay it for a few years.
Yeah, so this is something which we call as primary prevention. You don't let the disease to happen.
Yeah.
Right? And even if you got it, if you take care of all this, you are going to help us with secondary prevention. Right?
Yeah.
So that is very important. Stroke
So
happening.
young age stroke is something which is right now we do have cases when young age strokes are happening.
Yeah.
Although at times people are correlating it to stress, people are correlating it to excessive physical exercise, But if you can put some light, what all factors which are to be seen when we are talking of young age stroke, and is there anything which we can do it about it?
I think, Dr. Nag, that's a very valid point. This is something which we call as stroke in young. So it's usually the sixth or the seventh decade which we see the stroke happening.
Yeah.
But nowadays we are seeing it in the third or the fourth decade even, that is in 20s or 30s. Now, there are certain extra risk factors. Whenever we get a person who is young and got a stroke, the list of investigation increases because there are some untraditional risk factors like genetics or some hyperhomocystinemia, which is a very common problem. It can be secondary to B12 or folate deficiency as well. You know it better.
Yeah. Matlab in our routine checkups, we are finding Indian population, even 30% of people are coming with hyperhomocystinemia. And parallelly, their B12 and folates are low.
There are other risk factors like genetic risk factors, and we have certain thrombophilia panels. And in females specifically, there is some autoimmune disorders like vasculitis, or even in males, we have other disorders like Behçet's or something which can cause disorders of any vessel wall problems like strokes. More importantly, we are seeing role of traditional risk factors even in young people, and that's, I think, the sedentary lifestyle and is something to be blamed for. Targeting the traditional risk factors, in addition searching for any important other risk factors, is something which we should always be looking for.
Even at the traditional, you're seeing this shift in age, early shift
Yes,
in age in
definitely,
stroke?
definitely. So even in stroke in young, other than those I mentioned, we always look for the traditional risk factors. And in the one of the subtypes of stroke, where what we call as cardioembolic stroke, where the clot travels from the heart to the brain. Now here we have to look for atrial fibrillation. That is an irregular heartbeat. So people don't understand at times that your angiography is normal, your so where did the clot
AF
come
is an
from?
isolated part, so
Yes.
even if you have done your ECG,
Yes.
echo is normal, but
Now,
no one has done the Holter, so
Yes, so Holter is comes handy because a 10-second ECG cannot rule out any heart rhythm abnormality. Even at times, 24 hours ECG doesn't rule out it, but that's the minimum which you can do. And there is always a role for looking for it, because the type of blood thinners which you will be reading to prevent another episode of stroke is different from what you get it if you're any of the arteries blocked directly, or it's something coming from your artery.
And with this increase in age overall lifespan, so age-related AF is must be getting higher, leading to higher stroke.
Yes, and again, hypertension is a very important risk factor for AF even. So this is all about what we call as the ischemic stroke, or when the disruption of the blood supply has happened because of the blockage of an artery. 85% of the cases do get a blockage and then result in a brain attack. But there are brain attacks or strokes which are of hemorrhagic type. So where leakage of the blood vessel happens and blood spills into the brain. So again, the risk factors are, most importantly, is the hypertension, but there could be some congenital malformations of the blood vessels also, which can lead to such type of stroke in the young people. We have Moya disease. All of these disorders, the public should be aware that a CT scan at the onset of the new symptom can basically decide upon these to classify.
And the whole treatment changes.
Yes,
for
obviously. In one type, you can use a blood thinner. Other type, it's totally contraindicated. So the important thing is time. Acute management of stroke, the window is most important thing. And then comes the secondary prevention. That means you prevent the further expansion of the stroke and the recurrence of stroke. And the third important part is rehabilitation from that stroke. So once you got the deficit, like I told you, that any weakness of the limb or legs, any speech deficit, any language deficit, any swallowing difficulty. So all of that needs, again, retraining of the brain, because the recovery is going to happen and it's going to take weeks to months, whatever recovery it's going to take, because it's a natural process. So you have to make arrangements. You have to, again, give the brain that environment to heal. Okay, and this healing may be partial also. So people will be left with some residual weakness or deficits, as you rightly mentioned, and that is something which we call as morbidity. So yes, stroke can be life-threatening also, but it leaves you with disability. So better to prevent rather than face it, and be serious about your TIAs. That is all which I want to emphasize. And management of stroke is always a team effort.
Yeah.
So we have our speech therapists, our physiotherapist team, which really help us and bring us our patients, and not to undermine the efforts of our nursing staff.
Fairly
Recovery
understood,
of our
ma'am. This is
patients and
something
management.
which is a long term. What all we can prevent, what has happened has happened.
Yeah.
How to take it forward is something
Yeah.
a whole team work. Moving on from stroke to a different disorder, fits, seizures, epilepsy. So are they same? How it works?
Okay, so epilepsy and seizures are not one thing.
Yeah.
Okay, we need to understand. Yes, commonly people understand seizures as or fits, and epilepsy is a term which people often use very loosely.
Yeah.
So that is wrong. Epilepsy is a tendency to have recurrent seizures. Now it can have a cause, or it can happen without a detectable or a very, you can say, very clear cut cause. Uh, Now, seizures can be secondary to either a low glucose levels or low sodium levels also. So here we don't call it as epilepsy,
Yeah.
right? So uh, seizures is a symptom which usually happens because of the abnormal extra electric voltage which happens, or spark happening inside your brain.
Yeah.
Now, if it happens inside a particular area of the brain, and then that part of the body, because your brain controls your opposite side, right? So if it happens in a particular area, the corresponding part, either it moves or you have a sensory abnormal sensation, uh, or a symptom related to that spark, is something which we call as focal seizures, which people commonly understand as an epileptic fit. But that is the uh, generalized tonic-clonic seizure,
Yeah,
right? So where the person falls, the body becomes stiff, and then it jerks, there is a frothing, and then becomes loose, there is an incontinence of urine or stools also. You need to understand for public that every fit is not epilepsy. And it's very rightly mentioned. Another myth about epilepsy I want to really highlight over here is that it's not because of any supernatural power, or something which is overpowering you. So it's a neurological disorder. So another thing is, every loss of consciousness is again not seizures or epileptic fit. It can be any other reason. It could be just a sudden dissemination, like disruption of the blood supply to the brain globally, which we call as syncopal. Like the kids, they faint in the assembly, right? It's not necessary that they got a seizure or a fit, right? What you rightly mentioned is that there are people need to understand there are certain do's and don'ts when you see someone convulsing in front of you, right? Having a seizure in front of you. So this is something which we call as management of seizures outside the hospital settings, right? And that is more common than even getting a seizure inside the hospital. So if you see someone who is seizing in front of you, the best thing you can do is not to restrain. So that is the big no. Do not restrain the person. Just turn the person gently to one side, so that in case he or she vomits, the vomit should come out and should not go into the lung. And then another important aspect is that you need to clear the surroundings, so that the jerking, because if you try to restrain that time at that particular time, you are going to injure the person more than, or you will be doing more harm than good to that person. Another big no is, don't put anything inside the mouth. People have a tendency that they put either spoons, anything they come handy, even they try to open the jaw. So that is totally wrong, because if you put something, the force of the seizure is so much that the person can bite the spoon, it can break, and even it can go into your airway and can block it. Another thing is, you can injure your finger also with the bite. You please do not put any water. They're trying to make the person drink once the seizure is over. Please don't do it. Don't try to make the person sit. Let him calm down. Once the seizure is over, let the person lie down calmly over
And
there
generally,
only.
what is the time duration of a seizure?
Yeah, so usually a generalized tonic-clonic seizure, or the episode which people understand, is the last somewhere up to 2 minutes or so. If this goes beyond 5 minutes, that is when immediate medical help is definitely required. So you should look for the any mark, because we tend to give some identification, or we ask our people with epilepsy to carry, those who know it,
Yeah.
right? So they
Right.
to carry some tag or even a bracelet saying that they whom to call in case of any emergency.
Yeah.
So these you should look for. And these days we ask them to carry a certain nasal sprays also, which we can give, people can administer if the seizure is too prolonged, right, going beyond 2 to 3 minutes. So people can, or people at home, their family members, their caregivers, friends, they can give puffs of those nasal spray and can basically curtail the attack. Now, the biggest mm, threat is because of the wrongdoings at the time of handling these acute seizures. Because people tend to carry such people, make them sit. So that is the time they get injured.
So great to know how to deal with an epilepsy patient or a seizure patient when you encounter someone and outside the hospital. Moving ahead, can you elaborate on the causes of epilepsy? What are the diseases which can lead to epilepsy, etc.?
Yeah. So causes as per the age.
Yeah.
Because the causes would be different if the seizures are happening or the epilepsy starts early in the childhood, or even it can start at newborn, where the genetic causes usually predominate. And in the young adulthood, the very common types of epilepsies, as I discussed, there are certain types of epilepsies which we call as primary generalized epilepsies. Like the most common among them is the myoclonic epilepsy, like where people get certain jerks, like startle type response. They give history that they have a tendency to drop objects, especially in the morning. They get the seizures, and the very common trigger for their seizure is sleep deprivation, if they are not able to sleep properly, and that's around usually the early or too late adolescence, like 14 to 16 years of age. So these people who get these startle responses, early seizures, there is something which we call as juvenile myoclonic epilepsy, right? So these types of people, they and this is the peak time of their studies also. By around 10th to 12th standard, they get these seizures. I'm trying to highlight this type of epilepsies, it's not the medical knowledge which I want to transmit, but that these people, they with epilepsy, which is something, they are suffering from a type of epilepsy which is pharmacoresponsive. That means if they are diagnosed on time, they are given the optimal treatment, they can lead a perfectly normal life, right, with good control of seizures. And what we call as good control is, and the target of treatment, zero seizures.
And just for viewers' benefit, can you please tell this juvenile myoclonic epilepsy, what will be the frequency of attacks?
No, it will be very different for everyone. Okay. It's not going to be the same for all. But the most important thing to understand is that here you need to understand that flashing lights, they can trigger. Okay. So these days now we have all the screens which have got a good refreshing rate.
And even they are studying on the very same screens.
Yes. So if the only thing which we guide people with juvenile myoclonic epilepsy is to avoid playing video games or watching the screens from a close distance. So if they watch televisions, they watch even action movies, that should be with the ambient light on. Okay. So that's something which can decrease the chances of getting a seizure. And they should definitely be very particular about their sleep and avoid sleep deprivation and be regular with their medication. Because the most common reason for any breakthrough seizures is poor drug compliance.
A very important topic, because at times as a doctor, even a friend's family comes up that we are taking medicine for the last 3 years. अब कोई seizures नहीं आया, तो we have stopped. Now it has again come. Yeah. So that medicine is not treating seizures. So that is very important.
So as I told you, you have to be very clear about your targets of treatment. Yeah. So when it comes to epilepsy or seizure control, then the target is not when you will stop the medication. The target is whether you are able to control your seizures or not. So if you are able to control it 100%, that is something which we are striving for. Now, withdrawing the medication, anti-seizure medication, is something which is secondary.
Yeah.
If there is a reason which is reversible for the seizures, like I told you that low sodium, low glucose, or a brain infection in that part. Like people do get something which is very common in India, that is neurocystic sarcosis.
Yeah.
It can come from any raw vegetable. So again, if you talk about this as a cause for epilepsy, it's preventable. Because if you have good food hygiene, you can prevent this disorder.
Definitely.
Right. Second, if such disorders where you can go away with the cause, you can definitely have a stipulated duration of treatment. Obviously, there is no set formula that when you are trying to withdraw the medication, who will get a seizure again or not. Because as I mentioned the word anti-seizure medication, so the nomenclature has changed from anti-epileptic drugs to anti-seizure medication. Reason being, they are not treating your epilepsy. They are controlling your seizures. So we have to be very clear. And I tell every patient of mine that anti-seizure medicines have to be looked like a MCV. Right? You know that your house has got a tendency for voltage fluctuation. Why do you put an MCV? Because that is going to give you a safety for your appliances. And it will trip whenever there is a voltage flux. So that is the job of the anti-seizure medication. Right? They are never going to help you with the voltage fluctuations. They are bound to happen. But this will save your appliances. So here your appliance is your brain. So that's going to prevent a bigger attack, which we just discussed. And these drugs is only, and once you put your MCV, you just forget it. So you start taking your medication. Your target is to live a normal life. So that is something you should be targeting.
So it is practically, they have to understand it's like diabetes or a hypertension or a thyroid medication, which if started, have to be continued and have to stick upon. And any withdrawal of medicine has to be very much well guided with the neurologist, whether it was a reversible cause or not, etc.
And you just asked about the causes also. I would like that another preventable cause of headache is, the epilepsy is the head injury. And road traffic accidents is something which are preventable. So if we talk about epilepsy, secondary to head injury, resulting from road traffic accidents, they are preventable.
And so why very high incidence of epilepsy is because of that.
And that's a very common cause for seizures and epilepsy in young patients. So we have to consider road traffic accidents as a public health issue.
Moving forward, let's talk about something which is my concern also. That is forgetfulness / dementia. So if you can just put, if I'll put myself over there, I feel I'm not that sharp in terms of remembering things. And that is also practically what I'm doing today. My old things are very much settled in my brain, but not that great registry of memory now. So how it works?
Good, you didn't forget to ask this question. So I would say that forgetfulness should not be equated with dementia. First of all, that every forgetfulness is not dementia. And dementia is not normal aging. So these two important, I would say, messages, which through your podcast, I would like to tell.
Okay, so what is a dictum that since you are getting old, you bound to forget things is not something which is
it's not correct.
Okay.
So forgetfulness, yes, everybody forgets. And I think that's a way of nature has come up with the decluttering of the brain, you can say. But yes, not able to remember important tasks, which could be possible because of your preoccupation with a lot of things, if you are multitasking at a time. But if it is happening on a very regular basis, if it happens in your day-to-day activity and you incur certain specific losses like financial losses, you really forgot your something, you can't forget to take money or if you have lended. So usually people don't forget it. People, if they incur important losses because of that, or totally forget to bring the child from the school, then it should be taken with a pinch of salt. Otherwise, forgetting in day-to-day activity should not be much pondered upon. unless it's a routine affair, it's out of the box. And the another important aspect is that forgetfulness in young people, there are certain medical conditions which should be always looked at. This is something which we call as reversible causes for forgetfulness. The common ones is the B12 deficiency. It's a nutrient which basically helps you
And
with
in
multitasking.
Indian scenario, in an Indian diet, B12 is already low.
Yeah. So again, yes, Indian vegetarian diet is slightly low on B12, but we can compensate for it by having good amount of curd
Yeah.
or almonds. Because curd is rich in bacteria, where again you can get a lot of calcium, protein, and B12
Yeah.
together. The another medical condition which is usually implicated in forgetfulness is hypothyroidism. So, which is really very common, and it's a reversible cause of dementia.
Yeah, yeah.
So, or I would say forgetfulness.
Yeah.
The preventable causes, I would say, about forgetfulness is one of the common with now young people also, which I would say, or cognitive decline. Better word is cognitive decline, where your other brain functions also get affected. Like you said, multitasking. It's not a memory dependent only thing. It's a set shifting thing.
Yeah,
So
yeah.
you are looking at one thing at a time and then shifting the whole set at the same time to the other thing.
And every brain is not programmed for multitasking.
Yeah. So you should be looking at is obstructive sleep apnea. That is something which you should be always because earlier another myth is that snoring is equating to good sleep quality, while it is the other way around. So
So
snoring.
OSA is not just cardiac; it leads to dementia also.
Yeah, it's a very common cause of morning headaches.
Okay.
It's a very common preventable cause of hypertension.
Headache for both, even for the spouse.
Yes, obviously their sleep gets affected, so you will have poor quality sleep.
Yeah.
So the person who's affected with OSA definitely has got a poor quality sleep because of the frequent disruptions of the sleep due to diminution of the oxygen supply to the brain, due to the cycle of snoring, and then a part of apnea, that is lack of breathing at that particular time, and which results to more daytime sleepiness. This is something which is very frequently, if you ask people, yes, I feel sleepy the whole day, and or if given that opportunity, I will doze off. Maybe waiting for my turn on the traffic lights, or just watching television, I just doze off, sitting idle. This is something excessive daytime sleepiness which you have to look for. And another thing is a non-refreshing sleep, which they usually complain of. So when you suspect OSA, so another important risk factor for OSA is obesity. So you have to look for these disorders. So obesity can be secondary to your second sedentary lifestyle.
Yeah.
So you can go for, and it is a risk factor for diabetes. It is a risk factor for hypertension.
Yeah.
And so all of these can be prevented if you just control your body weight.
Yeah.
So, and in the elderly or age group where Alzheimer's is one of the very common reasons for dementia, right, beyond 70 years of age, the other common type, which I think is more important for Indian subcontinent, is the vascular dementia. We talked about stroke.
Yeah.
So strokes, having silent strokes, can also lead to cognitive decline.
Okay.
And here I would like to mention that dementia is not only about memory impairment or forgetfulness. There are other functions of the brain, like executive functions. How do you prepare a cup of tea? How do you do your daily chores? Right? How do you plan your whole day? Right? How do you navigate through your home or through the places you often visit? So people tend to forget those paths also, so which are more commonly affected than even memory or your behavior. That is again a brain function. So these all things have to be understood. That memory impairment alone may or may not be there, but it is not sufficient or not necessary to call it as a dementia.
Got it.
So Alzheimer's is something which you, I think you know about, that it's a common type of dementia. But at the same time, again, if we talk about prevention of dementia, then not only nutritional deficiencies, control of your thyroid issues, control of your risk factors, and prevention of stroke can or cardiovascular risk factors, you can prevent dementia as well.
As you talked about Alzheimer's, there's a lot of like in India, you encounter Alzheimer's far less than developed world. Is it lack of awareness? Is it the incidence overall life expectancy, or is it really there is something different when it comes to Indian population?
Yeah, I think that's a common myth. Now, with the more and more aging population in India, we are definitely seeing more Alzheimer's. And in the beginning of our discussion about dementia, I mentioned that dementia is not normal aging. So, dementia, specifically Alzheimer's, it is a type of dementia where memory impairment is important, but the visuospatial difficulties, navigating through common pathways, right? So they also get affected. So this is something which is very common and obviously a disease which is seen usually beyond the age of 70 years.
Let's move to one more topic which I like to cover today.
Okay.
That is tremors and Parkinsonism.
Okay.
So we all know that tremors is one of the essential symptoms on which you look at Parkinson's, but Parkinson's probably something more than tremors. And are they equitable? So I would like to know about it.
Okay, so as I gave you certain points which I want to communicate to the audience, here I would like to mention that every tremor is not Parkinson. First thing, a more common type of tremor is what we call as essential tremor. This is something which we see in even young people, and where both the hands they tremor, and it's more of a involving both the hands and is more prominent while you are performing a task.
Yeah, intention
Right?
tremor.
Intention tremor or action tremor. So while you are holding on, trying to reach to a cup, or so your hand will shake.
Yeah.
Right? And it is something which interferes with your daily living more than Parkinsonian tremor, because it affects your activities, your writing, your signing capabilities. The Parkinsonian tremor, on the other hand, it's a rest tremor. That means it will be more prominent when your hand comes in a resting position.
Okay.
It has got a pill rolling character to it. That means just like जैसे कोई माला जपता है.
Okay.
Right? So it is a pill rolling character. It will be more prominent when you are doing some mental arithmetic or you are walking. Okay. And it has to, like, this is just seen in up to 75% of the patients who will have tremor as one of their presenting or will have tremors in their whole
symptom.
spectrum of the disease, who are suffering from idiopathic Parkinson disease or Parkinson disease. Now, Parkinson disease, again, as we understand, is a disease of elderly people.
Yeah.
Right?
Age is the...
And is one type of Parkinsonism. As you said, you used the word Parkinsonism. I am very glad to hear that you didn't use just Parkinson disease. But people need to know about Parkinson disease also. And the mnemonic which we always tell them to remember, what we call as the motor symptoms of Parkinson disease is TRAP.
Yeah.
Right? So that is tremor, which we discussed, is the pill rolling type, rest tremor. And the R stands for rigidity. That means the stiffness in the body which you feel while you limp, like wearing clothes, you feel a rigid knee, you feel, and many a times people attribute it wrongly to arthritis, which usually also gets
that same age. So.
Yes, same age group. So people very wrongly attribute it to osteoarthritis or something. Then is the A is for akinesia or bradykinesia. Now, akinesia or bradykinesia is slowness. That means the time you usually used to take to perform a certain task, changing clothes, taking bath, eating your meals, that gets prolonged. So P is for postural instability. So TRAP, tremors, rigidity, akinesia or bradykinesia or slowness. P is for postural instability. That means you have an increased tendency to fall because of imbalance while walking. So that is something, and that's usually seen later in the disease course, not early on. Right?
Yeah.
So these are the motor manifestations. Very surprisingly, and I would say interestingly also, there are certain non-motor manifestations of Parkinson, which people should be aware of. and they come many decades before these motor manifestations.
Okay,
So that is something which
you get a disease early diagnostics, so obviously you can delay
yeah,
the motor.
but again, they being so non-specific that every
difficult.
constipation cannot be labeled as Parkinson.
Yeah,
But
yeah.
constipation in a Parkinson patient, they can precede the motor manifestations by 2 to 3 decades, right? So constipation is a very important symptom,
And
right? Complaint
does
also.
the radiological signs come at that time? If we
No.
investigate that?
No, not at all. So I told you the symptoms. That's the only neurological disorder which, after 200 years of its first description by Professor Dr. James Parkinson, by just observing a person suffering from Parkinson disease, even we today diagnose Parkinson disease clinically. By seeing at the signs, we see the drug response. We tend to rule out and try in the history. We try to find out, as you rightly mentioned, that there are certain things that come early on in other types of Parkinsonian symptoms. Like I mentioned, that postural instability is late to come in Parkinson disease. So, and other associated features, like if you have decreased smell, which is more commonly seen with Parkinson disease. Right?
Yeah.
You are not able to get what is being cooked in your kitchen.
And
So,
is there anything, any type of what all other Parkinsonism things which are reversible, treatable?
yeah, so we have other treatable types of Parkinson's, or at least preventable, is something which we call as drug-induced Parkinson.
Yeah.
Right? Very commonly used prokinetic, or some people have constipation or GERD symptoms. So very commonly they get prescribed levosulpride.
Just for audience, GERD is
That is gastroesophageal reflux issues, right? So reflux is very common, right?
Yeah.
So many people get prescribed levosulpride. Now it's a drug which has got a box warning to be used for a stipulated period of time.
Yeah.
But because it's a very potent drug, people get such a good benefit that
And they don't go to
without
their
medical
doctor back
prescription,
and they'll keep on
they
taking it
tend
forever.
to use it for a longer period of
Yeah.
time. So when taken for a longer period of time, if someone specifically has a predisposition, so we come across a lot of patients who, on closer look or on detailed asking, they lend us that yes, they have been using it for 2 to 3 months continuously, and they land up with Parkinsonian symptoms. Now, when we talk about Parkinsonian symptoms, again, the common thing would be that they will be slow, they will be rigid, they will be stiff, but not the trap whole trap. The tremor may or may not be there, but rigidity is must, the stiffness is must, the slowness is must. So, but the other symptoms like postural instability, if it comes early, that pinpoints towards another Parkinsonian symptoms, right? If now similarly, that postural instability, specifically someone walks with short steppage gait, which is very classical for Parkinson also, and they have then they develop urinary incontinence and also develop forgetfulness, which is a triad, right? They can have, especially the elderly population, they can have what we call as normal pressure hydrocephalus. Okay, so this is a disorder which can be diagnosed through imaging. You asked me that do every Parkinson patient need imaging? This is the set of patients who need imaging for sure, because here are certain signs on MRIs. There are certain specific types of MRIs which can guide us to do certain tap
And
of
this
the
is
CSF.
the area where you can treat it forever.
Yes, because it is something which the patients are going to get better with a type of particular type of surgery. And the symptoms are going to be controlled forever.
Yeah.
So it's a potentially treatable disorder.
Great to know such a vast field. I think you can talk forever for it, but really great. And yes, brain aids prevention will be our motto. Thanks a lot, Dr. Manish.
Thank you, Dr. Nag. And thanks again, Tata 1MG, for calling me for this podcast, interesting podcast. Thank you.
Thank you, everyone, for joining today's podcast. So now we know our headaches better. Stay healthy, stay wise. Till we at Tata 1MG, bringing care to your health.